Welcome to this video on Chyle leaks. Before we start, ask yourself the following questions. What is chyle? Where does chyle travel from and to? How do you diagnose a chyle leak? And how do you treat a chyle leak? Chyle is a mixture produced in the digestive tract, and this consists of lymphatic fluid and chylomicrons. Lymphatic fluids contain protein, white cells, electrolytes, vitamins and elements. The chylomicrons contain triglycerides, fatty acids, cholesterol and protein. These are produced during the breakdown of long-chain fatty acids, such as those found in olive oil. By contrast, short and medium-chain fatty acids tend to be absorbed directly into the bloodstream. Chyle collects in an area called the cisterna chyli, which is found at the level of the second lumbar vertebra. It then travels through a duct vertically alongside the lumbar vertebra, entering the thorax along with the aorta at the aortic hiatus. It usually emerges at the root of the neck, on the left-hand side, lateral to the esophagus, medial to the omohyoid, and behind the internal jugular vein. From here, the route can be variable, as it travels vertically, usually around 3 to 5 centimeters above the clavicle, but it can sometimes go higher. It then curves back round and terminates either as one vessel, but is also known to have bifid or trifid configurations. Most frequently it terminates in the internal jugular vein. Sometimes it terminates in both the internal jugular vein and the subclavian vein, and least frequently it terminates in the subclavian vein alone. Given the variable anatomy of the chyle duct, it is not surprising to sometimes encounter chyle leak during head and neck surgery. Pooling of clear fluid within the surgical field is suggestive of chyle leak. After some minutes, this clear fluid becomes more jelly-like in consistency. Positioning the table in a head-down position or asking for a Valsalva maneuver will make the flow of chyle more apparent. A high drain output with a milky consistency is suggestive of a chyle leak, but though the diagnosis can be confirmed with biochemistry tests. If the concentration of triglycerides is greater in the drain output than the patient's serum, or if there are chylomicrons within the drain fluid, a chyle leak can be confirmed. If you notice a chyle leak during surgery, you would want to find the exact area where it's leaking from, perhaps using surgical loupes or operating microscope, and oversew this area using a non-absorbable suture or surgical clips. A local flap can also be used to cover the area. If the chyle leak's been detected post-operatively, the management depends upon whether it's draining more or less than 500 ml a day. With low output leaks, the aim is to try and reduce chyle flow to allow fibrosis to heal the leak itself. The strategies to do this revolve around activity, nutrition and medications. Patients should be placed on bed rest with stool softeners to reduce intra-abdominal pressure. This will help to reduce the flow through the chyle system. As chyle is produced by the breakdown of long-chain fatty acids, patients should be placed on a low-fat diet to reduce the production of further chyle. Pancreatic lipase inhibitors such as orlistat can also be used to reduce the production of chyle further. If these measures are not effective, a short period of TPN can be considered. Octreotide, a somatostatin analogue, also helps to reduce chylomicron production, and so can be useful in the management of chyle leak. A high output chyle leak requires careful monitoring of the patient's fluid balance. Patients should return to theatre for arrest of the chyle leak, using the techniques previously described. If the chyle leak persists, colleagues from interventional radiology or cardiothoracics can be involved for definitive management. Options include embolization of the thoracic duct at the cisterna chyli, or clipping the thoracic duct just above the aortic hiatus. I hope you found this video useful.